All right, this is a rehearsal, a practice rehearsal for a presentation for a workshop at the Brochet Foundation. So this is titled Psychiatric Futility, Key Lessons from ICU Guidelines. So I'm Thaddeus Pope, and we're going to be talking about the concept of futility. So here's the roadmap for the next 20 minutes in 3 parts. First, what's the context? Where and how is futility used in healthcare? Second, a point about vocabulary, and that's that there's been a strong caution to stop using the word futility. And third, another point about vocabulary, which is, what's the recommended use of the word futility? Okay, so what's the context? Well, primarily it's used in the intensive care, critical care medicine context. So these are patients who are catastrophically, critically ill, right? So some examples might be the patient is 101 years old with metastatic cancer, or the patient has suffered an anoxic brain injury and is now in a persistent vegetative state or unresponsive wakeful state, right? In these sorts of situations, clinicians often recommend comfort measures only, right? They recommend that we withhold or withdraw mechanical ventilation, dialysis, CPR, artificial nutrition and hydration, and interventions like that. And there's a lot of vocabulary in this space, but what the clinicians are doing when they make this recommendation is they're distinguishing between treatment that is appropriate from treatment that is inappropriate, or what is advisable versus inadvisable, or what is proportionate versus disproportionate, or what is beneficial treatment and what is non-beneficial treatment, what is effective treatment, what is ineffective treatment, when is it neglect to stop treatment versus when is it abuse to continue it, or what is treatment that is consistent with reasonable medical standards and what is treatment that is contrary or outside reasonable medical standards. So clinicians are drawing these lines in these cases. Surrogates often agree with the comfort measures only recommendation, but not always. And there is a fair amount of conflict and dispute, right? Because the clinician is recommending comfort measures only, but the surrogate wants continued life-sustaining treatment, right? The surrogate will not consent to the comfort measures only recommendation, right? And medical futility, the concept, is usually invoked in these conflict or dispute situations, because normally clinicians are supposed to follow, right, what the patient or surrogate wants. But here, the clinician is saying, no, I don't want to do what you want me to do, right? And futility is often invoked as a basis, as a reason, as a justification for saying no. So to recap, right, you go on PubMed and you type in medical futility, medically futile, and what you'll discover is 2 main things. First, it's primarily used in the ICU context. And secondly, it's primarily used as a justification for refusing treatment that the patient wants. Okay, second point is there's been a big push to just stop using the word futility in healthcare. So on Medscape, they have these really big surveys of like 10,000 physicians, right? And they ask questions like this: would you give life-sustaining therapy if you considered it futile? Or would you provide life-sustaining therapy at a family's request if you think it's futile? But how do the survey respondents understand the word futile in the question, right? Well, it's actually a lot like the parable of the blind men and the elephant, right? Because each one is touching a different part of the elephant, the tail, the tusk. And so each has a different understanding of what is the nature of that elephant. Well, here too, right, there's a lot of variability from physician to physician in how they understand futility. This is an Australian study, literally just asked, what does futility mean? And what they found is you get a lot of different definitions, And in fact, some other studies show the same thing at the hospital level. So it's not just that there's variability from clinician to clinician to clinician, but also from hospital to hospital to hospital. So because of that, in 2015, we published what is now known as the 5 Society Statement. And the 5 societies are the American Thoracic Society, the Society of Critical Care Medicine, the American College of Chest Physicians, the American Academy of Critical Care Nursing, and the European Society of Intensive Care Medicine. So it's the 5 Society Statement. And a key message of the statement is to just stop using the F word, futility, because it has too many meanings. And worse, it's often used as a mask to hide what's really going on, right? It's hiding value-based judgments behind a mask of science, right? So futility sounds very objective and scientific, but in fact, when physicians say something is futile, what they often really mean is, well, we could do it, but it's not worth the resources, or this patient has an inadequate quality of life. So what's recommended instead is a new vocabulary, and this comes from the 5 Society Statement. So what they recommend is taking this concept of futility and breaking it down into smaller pieces, smaller concepts. And they break it down into 4 parts: treatment that is futile, treatment that is prescribed, treatment that is discretionary, and treatment that is potentially inappropriate. So futile treatment, this is when the intervention cannot at all accomplish the physiological goals, right? So this is scientific impossibility. It goes back to the etymological roots of the word futility, which brings us to this Greek myth where these women are trying to fill up this bowl, right, with water, but you see that they cannot do it because every time you pour water in the top, it just comes out the bottom, right? So you cannot fill it. It's impossible. It's futile. And there are other depictions of futility. So the examples in the 5 Society Statement are first, right, antibiotics for a virus. Another example is antifungals for a myocardial infarction. And the third example is CPR when the patient already shows rigor mortis or dependent lividity. Another example, this one's not in the 5 Society Statement, but I think it fits, is ambulance protocols. Generally, the EMTs are supposed to transport the patient to the hospital. But even they can determine futility in some circumstances, and one of those is decapitation. Another example, which I think we might add, is ivermectin. So this became really big for the last few years. During COVID, a lot of patients wanted access to ivermectin to treat COVID. But the FDA, the CDC, all the pharmacy associations said, ivermectin doesn't treat COVID. It just doesn't treat it. It's a horse deworming medication. In fact, the FDA put out this tweet that said, look, you're not a horse, you're not a cow. Seriously, all, stop it. So this is the meaning of the recommended meaning of the word futile, right? Which is it's value-free, it's objective, right? It's a very bright line. So if you ask the question, may clinicians stop life-sustaining treatment? If it's futile, then you may and should refuse to provide it, right? So to recap now, you should only use the word futility when there's a 0.0% chance of effectiveness. And if we move over now to the anorexia context, you see that in studies like this recent study from Switzerland, that they found that, as in the intensive care context, that many physicians have different concepts of futility or irremediability. But generally what they found is generally it's greater than 0%. So treatment is not, in the understanding of the Five Society statement, it's not futile. And we see the same thing confirmed by Cynthia Geppert and others. But one thing that these authors do is they started this document, right? Treatable, not terminal. And that's, I think, a little problematic because treatment can be both treatable and terminal. So let's say that the patient has capacity, right? The patient had capacity in the famous Lopez case, and some other studies show that a fair number of anorexia, even severe anorexia patients, do have capacity. So let's say that the patient with capacity refuses treatment. Well, she may therefore become terminal. In that situation, treatment effectiveness or potential effectiveness is irrelevant because treatment is unwanted. But treatment can't be both treatable and futile, right? So in the case of severe and enduring anorexia, treatment is perhaps unlikely to work, but it's not futile because it might work. Okay, one other way perhaps to capture this is terminal means that we won't treat. We could, but we won't because the patient doesn't want us to. But futile means we can't treat. We cannot treat even if we wanted to. Okay, so that's futile. The next concept in the Five Society statement is treatment that is prescribed. So this is treatment that may accomplish the effect desired by the patient. So it's greater than 0% chance, so it's not futile, but it is prohibited by laws, judicial precedent, or widely accepted public policies. So the examples in the Five Society statement are the patient wants you to falsify their clinical profile so they get a higher rank on the organ transplant waiting list. That might work, but it's illegal. Another example would be the patient wants medical marijuana or medical cannabis, but they don't qualify. They're not eligible for that. And another example is medical aid in dying. The patient wants that, but they don't qualify. Another example, this one's not in the Five Society statement, but you may know that in a lot of our southern states in the U.S., you often cannot get gender-affirming care or abortion. Okay, the point here is that if treatment request is legally prescribed, then the clinician may and should refuse to provide it. So that's prescribed. Discretionary treatment is the opposite of prescribed, right? So while prescribed is a red light, so stop, you can't do what you want, a green light is go, right? Proceed, do, doctor, do as you see appropriate. So this is where laws, judicial precedent, or policies give physicians permission to refuse to administer them. So the examples in the Five Society statement are brain death, right? Because once you determine death on neurological criteria, you can stop mechanical ventilation, even if the family doesn't want you to. Another example is anencephaly, right? Or probably any of these other serious congenital abnormalities. And another example is POLST. So these are portable do not resuscitate orders. Generally, you need the consent or signature of the patient or surrogate, but in Vermont, you can instead write a POLST without consent, without the signature, on the basis of futility if the patient's death is imminent in the next 3 days. Another example, this one's not in the Five Society statement, but I think it's ready to be considered discretionary treatment, is something called imminent demise futility. So this has been adopted by some professional societies like SCCM and the California Medical Association, San Diego County Medical Society. So let's say the patient has advanced metastatic disease or advanced multi-system organ failure from sepsis. They are in active clinical deterioration. They may code, right? And you can do CPR. And that's not futile because it might be able to restart circulation. But for how long? Right? The patient is actively dying. Their death is impending. It's imminent in a matter of hours. And that cardiac arrest is just the start of an inexorable dying process that cannot be prevented. And then one last example is, again, this is almost ready, I think, to be considered discretionary, irreversible coma. This is when there's no reasonable expectation that the patient's neurologic function will improve sufficiently to allow the patient to perceive the benefits of treatment, right? They're permanently unconscious. They can't talk. They can't hear. They can't see, can't communicate, right? May clinicians stop life-sustaining treatment? If it's discretionary, then the clinician may and should refuse. And that's because in all these situations, what the surrogate is asking for has been predefined as lying outside the scope of appropriate medicine. But it is worth noting that the Five Society statement is coming up on being 10 years old. And some things that used to be discretionary are not anymore. So it used to be, I think, there used to be a consensus that you don't need to treat babies with trisomy 18. You don't need to treat babies that are born at 22-week gestation, and you don't need to continue ECMO for certain patients. And the consensus on those has eroded, and I don't think there's still consensus support for not treating in these situations. Okay, so those are the first three categories: futile treatment, prescribed treatment, and discretionary treatment. All very small categories. Not a lot of cases fit into those categories. Most cases are what the Five Society statement calls potentially inappropriate treatment, or PIT, potentially inappropriate treatment. So this is where there's some chance that the therapy can accomplish the effect sought by the surrogate. So it's not futile because it might work. So the examples are mechanical ventilation for widely metastatic cancer, or dialysis for somebody who's permanently unconscious. We call these things futility disputes. And it might be because of the concept of quantitative futility. It's, the therapy is unlikely to work, or because of qualitative futility. Even if it works, it's not going to get the patient, to a sufficient quality of life. But in these cases, the disputed treatment might keep the patient alive, or in the case of dialysis for somebody who's unconscious, definitely will keep the patient alive. So the real question, the central question in these cases is not whether or not the treatment will work or not work. The real question is whether that chance of working or the outcome of the therapy is worthwhile. And that's not a medical judgment. That's a value judgment, right? Usually some judgment about that the burdens outweigh the benefits. And that's why they use the word potentially, this adverb, potentially inappropriate treatment. That's why that's in there. It's not just called inappropriate treatment, it's potentially inappropriate treatment. It's to remind the treating physician to be humble, to say, look, you might think it's inappropriate, but that's just you. That's just your idiosyncratic subjective judgment. You need to vet and confirm your judgment. And you do that by going through this process, these recommended steps. You go through this checklist. Basically, it means getting at least a second opinion and review by an interdisciplinary institutional committee. Why do that? right? Why go through all this due diligence and due process? First, it helps get consensus between the clinicians and the surrogates. But secondly, it helps assure that the decision that's reached is carefully considered. So let me just wrap up here, right? These are just a few lessons for psychiatry from intensive care, right? In the anorexia context, first, if you have a capacitated refusal, then you should stop treatment. And then it becomes irrelevant, I think, whether the treatment is futile, prescribed, discretionary, or potentially inappropriate. It's unwanted, and it doesn't really matter what category the treatment falls into. Second, if there isn't a capacitated refusal, then we could ask, well, is the treatment futile? Well, that's almost never going to be the case, because if the chance of treatment effectiveness is greater than 0.0%, and you really shouldn't say that it's futile, right? You should be more precise and transparent with exactly why you're saying that this treatment is inappropriate. Third, since there seems to be a lack of consensus guidelines in this space, it's going to be very difficult to say that it's prescribed, that treatment in these contexts is prescribed, and it's going to be difficult to say that it's discretionary because there isn't this, there aren't consensus guidelines or laws. So finally, that means if it's not futile, prescribed, or discretionary, that means that most situations of severe and enduring anorexia, that treatment at best would be potentially characterized as potentially inappropriate treatment. Thanks.